All right, Jess, you're not a doctor. Well, you are a doctor, but you're not a medical cancer doctor.
No, I'm not a medical doctor
So
at all.
we're going to do this in understanding what the doctor's saying and in layman's terms, right?
I'm going to try.
Okay.
So I've been waiting for this for a while. This is the pathology report. This has been available, and a doctor has talked to us about this, but I wanted to see it with my eyeballs. It's very much in God we trust, all others bring data. Show me the data. I just want to see the data. I think I'm actually the reason why doctors don't give people stuff like this.
Yeah.
But I wanted to see the pathology report.
Sure.
And so today we saw radiologist.
Yes.
And she brought in the pathology report. And so now I can see what the roadmap looks like. And I mean, this really is the roadmap for what's going to happen next. And so lots of things that I knew and lots of things that I didn't know looking at this report, and helps us to understand kind of where we're going based on what was inside of your body. So first thing, it says left neck dissection, which just means that they took all the lymph nodes out of your neck.
Yep.
And then left partial glossectomy. Glossectomy means tongue. They took a little bit of your tongue out. And partial pharyngectomy, which is part of the soft palate. So know that. Then looks at the lymph nodes, and what's really interesting about this is they actually took out 22 total lymph nodes.
I thought they took out 32.
Oh, actually, you're right.
Yeah.
No, because it says over here, exact number 22.
Oh, okay.
So I think that this is the total, and this is the aggregate kind of thing. So 2 of 10 lymph nodes, and they kind of divided them into levels. And my understanding is that the level really is just where they fell on in a section of your neck. I'm not exactly sure about that, but in level 2, which I'm assuming is closest to the cancer, 2 of those 10 lymph nodes were positive for cancer. And then 1 of those had a 0.6 centimeter tumor in it, and 1 of those had a 0.3 centimeter tumor in it. And the largest contiguous measurement of extranodal extension, and I'm going to talk about that in just a second. And then there were 9 lymph nodes and 3 lymph nodes, and all the rest of the lymph nodes were negative for cancer. So that is generally positive. Because cancer will spread through the lymph nodes, and so having these lymph nodes, just having the 2 out of the 22 is pretty great. What's not great is this extranodal extension, and so what that means is that if you think of a lymph node like a grape, that the skin of the grape has kind of burst and some of the cancer has spurted out. So the lymph node, when they took it out, was kind of broken, and some of the cancer stuff had squirted out like if you squish a grape. And it actually says in the report that the distance of the E&E, the extranodal extension, from the lymph node was 3 millimeters. So that's how far the cancer stuff had traveled outside of the lymph node. What that means to doctors is that your cancer has legs, it can move, it is moving. It's considered more aggressive because of that. So that is a risk factor for you for your cancer. Also learned that your primary tumor was 4.2 centimeters. That is bigger than we had been told, than we knew. We were told about 3.5, so it's bigger. And that bigger actually kind of matters, because in the phasing, or however they mark cancer, anything greater than 4 centimeters changes kind of how they look at things. So that 4.2 centimeters was an interesting thing to see, and the reason why it's good to look at reports, because we had heard 3.5, and this is 4.2. It does say that there's cancer in your deep skeletal muscle, which explains why your neck has hurt so bad as you've recovered. And it also says lymphovascular invasion identified, which is another risk factor. The next thing that is interesting is it says carcinoma measures less than 0.1 centimeter from the lateral resection margin, which means when the surgeon finished, he said that he got something called clean margins, which means that they cut until they got to skin that didn't have cancer in it. So they cut and they tested and they cut and they tested until they got to skin that didn't have cancer in it. And if they do that, then they have clean margins or positive margins. I think that's right. I think it's positive margins. Or maybe they want negative margins. I think they want negative margins. We'll just call it clean margins so we don't get confused. So in your case, they were able to get clean margins, but barely, just by 0.1 centimeter.
I'm going to go with 10 millimeters.
10 millimeters?
That feels longer to me.
Yeah.
Feels like a little more.
Feels like you got a little more space.
Yeah.
This is like man math, right?
Thanks.
Okay. So, and then the other thing that we learn from this is that it's P16 positive, which we've talked about. We knew that already. We've kind of known that forever. P16 positive is the better cancer. If you're going to get throat cancer, go with P16 positive. And then we get a classification. So your tumor is actually T3N1. So the T is the staging of the tumor. Your tumor is stage 3. And then the staging of the lymph nodes is N1. So that's actually the classification of his cancer. There's actually one more level of classification. You can get an M number, and that's the metastatic number. We don't have one of those numbers yet, and that is a good thing because they haven't found it in the rest of your body.
Yeah,
hasn't moved anywhere. So, given all of those things, there's really the big deals are the extranodal extension, the E and E. The size of the tumor, the lymphovascular invasion, the margin that was very, very close. And then also we found out today that because of your blood clots, that's another risk factor. So I asked the doctor and she agreed. So he has all of the risk factors for aggressive cancer. And she said, yes, that was one way to look at it. That you had all of the risk factors for aggressive cancer. So she showed us this chart and she brought this in, and I think because she wants to be my very best friend and knew that I would enjoy the data. So this chart is
it's a decision tree.
It's a decision tree for how to respond to T3N0 through 2 cancer. So you go through the process, and in this case, your pathology says you have adverse pathological features, all those things that we talked about, all the risk factors, and you have enough of the risk factors that they want you to participate in systemic therapy, which means both radiation and chemotherapy at the same time.
Sure enough.
So that is the recommendation for the doctor, and most likely where we will end up.
We got a few more things to do to check things out and make some decisions. So we'll get a PET scan hopefully done this week and find out if there's anything else weird going on with my body.
Right. That'll help us make decisions about how fast we have to move and those kinds of things. And then they also recommended that we go if we're going to get a second opinion, which we want to do, that we go to the Proton Center and see what their recommendation is and if you're a candidate for that. So proton therapy is more likely to be, well, I guess I should say less invasive, more likely to be less invasive, which is too many words, causes less side effects overall. They're able to target the tumor more precisely, and they don't have to kind of bounce radiation around all over the place. You might be a candidate for that, you might not be a candidate for that, but we're going to find that out. Either way, if you end up with proton therapy or not, most likely the recommendation will be chemotherapy concurrent with radiation. So that will happen at the same time. The doctor did a good job of explaining that it just makes the kitchen hotter. but it doesn't really, and it changes the outcomes. It increases the likelihood that they'll get all the cancer, but it doesn't really increase the side effects necessarily because they're happening at the same time.
I'm already going to be miserable.
Right. And the majority of the bad side effects come from the radiation anyway.
Right.
And that's a part of treatment no matter what.
Yep.
So adding chemotherapy doesn't really change how things go too much. You'll
Right.
be miserabler, but if you're already miserable is where you are. So
yeah, I won't be not miserable.
nope, you won't be not miserable.
So there you go. Very good.
Anything else?
I don't think so. That was a good walkthrough of everything.
Next steps: PET scan, proton,
And then do some
evaluation.
planning.
and then we'll do some planning and we'll know some timing. All right,
Cool.
cool.